Once again, hello everyone. Today would start the topic of topography of lower extremity. In the topography of lower extremity, the first we would see the borders. Now, according to the borders, there is anterior and posterior border. Okay, anterior and posterior border. In anterior border, there is pubic symphysis, pubic tubercle, then there is inguinal ligament here. Okay, anterior superior iliac spine of the pelvis and iliac crest. Okay, this is iliac crest. Now, what is the posterior border? Posterior border is imaginary line drawn from the posterior superior iliac spine, okay, to the middle point between the second and third sacral vertebrae. This line, it is an imaginary line drawn from the posterior superior iliac spine to the second and between the second and third sacral vertebrae. Okay, and the border between the perineum and lower extremity is the groove of the thigh. Now, the lower extremity is divided into following regions: is gluteal region, anterior and posterior, it is in anterior and posterior femoral region, regions of knee, regions of leg, anterior, posterior, medial and lateral regions of ankle joint, dorsal foot region and region of the sole. Now, first we would study the topography of gluteal region. Okay, what are the borders of it? Now, superiorly there is iliac crest, this. Okay, inferiorly there is a gluteal fold. See here, this. Inferiorly gluteal fold. Medial spinous process of the sacrum and coccyx. Okay, and laterally is imaginary line drawn from the anterior superior iliac spine, laterally anterior superior iliac spine to greater trochanter. Now, next is layers. There is skin, which is thick, hair follicles are present on the medial side, sweat glands on the lateral side, sebaceous glands middle side. Subcutaneous tissue is divided into two by superficial fascia. Okay, superficial and deep layers are there. This superficial fascia has superficial and deep layer. Superficial is attached to the skin and deep layer has a fatty space continues to the lumbar region superiorly. Branch of superior and inferior gluteal arteries are present. Now, fascia covers muscle and is divided into three layers. Okay, first layer is first layer includes 1.5 muscle. Which muscle? Now, first layer of gluteus maximus, it covers inferior part of posterior side of iliac crest of the greater trochanter. See this one. Okay, and half layer of gluteus medius. Now, second layer, it covers 4.5 muscle. 4.5 muscle means which are those muscles? Those are half layer of gluteus medius muscle, full layer of superior and inferior gemellus. See, superior gemellus, this is, and inferior gemellus. Okay, piriformis, this is the piriformis muscle, and obturator internus and quadratus femoris. Obturator internus and quadratus femoris. Now, the third layer, the full layer of gluteus minimus, this one, and obturator externus muscle. Okay, now the localization of neurovascular bundles. Okay, the sacrum to spine, we need to remember these ligaments: sacrospinous ligament. See, this sacrospinous ligament and sacrotuberous ligament. Sacrospinous ligament, it is between sacrum to the spine, and sacrotuberous ligament, it is sacrum to ischial tuberosity. Fine. Now, the now these ligaments, these two ligaments, it forms greater sciatic foramen and lesser sciatic foramen. See here in this diagram, sacrospinous ligament, it is here. Okay, sacrotuberous ligament, it is here. Now these two ligaments, it forms two foramens. One is greater sciatic foramen and another is lesser sciatic foramen. Fine, up and below. Now greater sciatic foramen, due to piriformis muscle, it divides into suprapiriformis foramen, infrapiriformis foramen. Where it is? See, this suprapiriformis, infrapiriformis. This is piriformis muscle and it divides supra and infra. Fine. Now this suprapiriformis muscle, suprapiriformis foramen, there is superior gluteal artery, vein and nerve. In infrapiriformis foramen, the first bundle is sciatic nerve or atria commitans nervi ischadic. Second bundle is inferior gluteal artery, inferior gluteal vein, inferior gluteal nerve. Third bundle is internal pudendal artery, internal pudendal vein and pudendal nerve. Fine. Now these were about the foramen which is formed in greater sciatic foramen, which is divided by piriformis muscle. Now next is projection of the neurovascular bundles. The projection are superior gluteal artery. Now this superior gluteal artery, it passes through the line present between superior and medial 1/3 from the posterior superior iliac spine to greater trochanter. Okay, see, posterior superior iliac spine to greater trochanter, it is passing through this. It divides into superior and deep branches at greater sciatic foramen and lies in the wing of the ilium. Short branches to piriformis muscle and anastomosis with inferior gluteal artery. Superior branch divided on medial surface of the gluteus maximus muscle. Deep branch goes between gluteus medius and minimus muscle. Next is inferior gluteal artery. From posterior superior iliac spine to ischial tuberosity surrounded by inferior gluteal vein and nerve. Around the infrapiriformis foramen, sciatic nerve is there, lateral to the inferior gluteal artery. Pudendal vascular bundles are medial to this. Then this bundle penetrate to the fascia and gluteus maximus muscle. Now see, this is sciatic nerve. Okay, this is pudendal nerve. Fine. Inferior gluteal artery and nerve. This are the regions. Pudendal vascular bundle is to the medial and sciatic nerve is lateral to the inferior gluteal artery. Fine. Pudendal neurovascular bundle. It consists internal pudendal artery, vein and pudendal nerve. It passes from infrapiriformis foramen medially. Around infrapiriformis foramen, bundle lies between sacrospinous ligament and ischial bone. Superior margin of lesser sciatic foramen. Then these bundles passes through lesser sciatic foramen inferior to sacrotuberous ligament on the medial surface of ischial tuberosity. Sacrotuberous ligament covers obturator intermus muscle and fascia. This forms pudendal canal, which is also called as Elox canal. See, you can see this Elox canal in this diagram. Now next is sciatic nerve. Lateral to infraspinous foramen, medial to sciatic nerve. Posterior cutaneous nerve of thigh, sciatic artery, artery commentus nervi ischadica, which is located superficially to the lower margin of gluteus maximus muscle and covered by fascia lata. Now anesthesia of sciatic nerve, middle point between the medial margin of the ischial tuberosity and greater trochanter of the femur. Next is topography of hip joint. Now in this topography of hip joint, the articulation is between acetabulum, and head of femur. Okay, it is a simple ball and socket joint, multi-axial joint due to intracapsular ligament, which are ligamentum capitis femoris, ligamentum transverse acetabulum, and extrascapular ligament are iliofemoral ligament, okay, iliofemoral ligament, pubofemoral ligament, ischiofemoral ligament, and zona orbicularis. Okay. Now, acetibular labrum increase in size for articular surface. Largest lymph node is Pyrgov's Rosenberg's node. Now, weak places of the joint capsules are anterior weak place, which is between iliofemoral ligament and pubofemoral ligament. Posterior weak places is inferior margin of ischiofemoral ligament from ischial tuberosity and acetabulum to trochanteric fossa, where obturator muscle is located. Now, purulent processes of the para-articular space may spread to fascia of adjacent muscles through these weak places. Now, purulent process of joint capsule may spread to anterior direction, anteriorly to the medial compartment of the thigh between the pubic bone and pectinis muscle, from medial margin of iliopsoas muscle, to suprapatellar bursa from the lateral margin of iliopsoas muscle, and to adductor canal along the femoral vessel. In the posterior direction, under the gluteus maximus muscle through the fissure between the quadratus femoris and inferior gemellus muscle, to the gluteal region along the obturator internus muscle, medial circumflex artery and vein under the gluteus maximus muscle, to the gluteal region and fissure between the gluteus medius and minimus muscle along the lateral circumflex artery and vein, from the spaces between sartorius and rectus femoris muscles or from the tensor fascia lata muscle. Other directions are to the lesser pelvis, to medial side of the thigh, and to the posterior thigh and lateral margin of the greater trochanter of the femur. Now, to the lesser pelvis, it is from lateral surface of the obturator externus muscle, along the obturator artery, vein and nerve, through the obturator canal. Now, to the medial side of the thigh, posterior inferior weak place of hip joint along the fascia of the obturator internus muscle to lesser pelvis, to posterior thigh and lateral margin of greater trochanter of femur, penetrates to the anterior thigh and fascia of gluteus maximus muscle. Topography of anterior and posterior femoral region. Now, first is borders. What are anterior border? Anterior border as usual, pubic symphysis, inguinal ligament, okay, anterior superior iliac spine, imaginary line drawn between anterior superior iliac spine and greater trochanter. Okay, this is anteriorly. Posteriorly, there is gluteal fold as I have shown in this diagram. See, here is gluteal fold posteriorly and fold between perineal side fold and medial side of thigh to the pubic symphysis. Inferiorly, there is circular line drawn 2 fingers above the patella. This is patella, okay. Now the circular line drawn at the level of 2 fingers above the patella. Laterally, 2 vertical lines drawn till the lateral and medial epicondyle. Okay. Now next is layers. Skin is thick and movable, more hair follicles and sweat glands in the males. Subcutaneous spaces contain superficial epigastric artery, external pudendal artery, superficial circumflex iliac artery and vein, greater saphenous vein on medial side of leg, which moves through saphenous opening and joins to the and becomes femoral vein and drains into the femoral vein. What are the muscles? Muscles are anteriorly there is sartorius, pectinis, quadriceps femoris. Okay. Now this quadriceps femoris consists of rectus femoris, vastus lateralis, vastus medialis and vastus intermedius. The posterior compartment, which is also called, these are anterior muscles are also called as extensor compartment of the thigh. Posteriorly, the sciatic nerve, semimembranous, semitendinous, bicep femoris muscle is present. Now, this posteriorly, sciatic nerve, bicep femoris, long head, short head, semitendinous, semimembranous. These are also called as hamstring compartment. Medial compartment, there are adductor magnus, adductor longus, adductor brevis and gracilis. These are medial compartment. Now next is femoral triangle, which is also called as Scarpa's triangle. It is musculofacialis triangle, anterior region of the thigh. Borders are superiorly there is inguinal ligament, this. Medially, medial edge of adductor longus muscle, see, adductor longus muscle, and laterally sartorius muscle, see, sartorius muscle, adductor longus muscle, inguinal ligament. This triangle is the femoral triangle. Fine. What are the contents of this triangle? Which is femoral artery, nerve and vein. This. Now, projection of femoral artery and vein is midpoint of inguinal ligament to the medial epicondyle of the femur, which is also called as Keen's line. Midpoint of inguinal ligament to medial epicondyle of femur. Now, floor of this triangle is formed by pectineus muscle and iliopsoas muscle. Between this, there is sulcus iliopectineus, where femoral artery and vein lodges. Okay, keep remember. Borders of femoral triangle is inguinal ligament, sartorius muscle, adductor longus muscle. Inguinal ligament, sartorius muscle, adductor longus muscle. In the floor, there is pectineus muscle and iliopsoas muscle. Okay, see, pectineus muscle is here, iliopsoas muscle is there. Between this, there is a sulcus, which it is sulcus iliopectineus. It is very simple. Pectineus muscle, iliopsoas muscle, iliopectineus muscle. From this sulcus, femoral artery and vein lodges. Now, neurovascular bundles of the femoral triangle. First is femoral artery. It passes from the midpoint of inguinal ligament to the femoral triangle. Compression of this femoral artery stops the bleeding. Covered anteriorly by fascia cribrosa of saphenous opening. Artery is lateral to the vein. Look in this. Artery is lateral to the vein. Okay. Now, next is femoral nerve. Lateral to the artery. First was vein. Lateral to the vein is artery. Lateral to the artery is nerve. Okay. Van. Medial to lateral. Van. Femoral nerve. Lateral to the artery and separated by iliopectineal arc and fascia of iliopsoas muscle. Superficial branch perforates fascia lata through the sheath of sartorius muscle and innervates the skin. This is superficial branch. Now deep branch intersects with lateral circumflex femoral artery and innervates quadriceps femoris tendon and pectineus muscle. Deep femoral artery, two branches is medial and lateral circumflex femoral artery. Medial circumflex femoral artery is posterior medial to femoral artery and vein. There is superficial and deep. Superficial is supplied to gracilis muscle, and deep the space between pectineus muscle and obturator in externus muscle. There are two, ascending and descending. Ascending is between obturator externus and quadriceps femoris muscle, which anastomoses with gluteal artery, and descending is between obturator externus and adductor minimus muscle, which anastomoses with perforating branch of deep artery of thigh and obturator artery. This is posterior surface of the thigh. Next is lateral circumflex femoral artery. The lateral circumflex femoral artery has two divisions, ascending and descending. Okay. Ascending is space between sartorius muscle and rectus femoris muscle and ascends between iliopsoas muscle and gluteus medius muscle and anastomoses with superior gluteal artery on greater trochanter of femur. Descending is under rectus femoris muscle between rectus and vastus intermedius and networks to knee joint and anastomoses with popliteal artery. Next is projection line of the vessels. Femoral artery passes from the midpoint between the pubic symphysis and anterior superior iliac spine to the tuberculum adductorum femoris, which already I told, Keen's line. Posterior tibial artery 1 cm posterior to medial margin of the medial epicondyle of tibia to the midpoint between the Achilles tendon and medial malleolus. Okay, see, this is the Keen's line. Anterior tibial artery, midpoint of head of fibula and tibial tuberosity to the midpoint between the medial and lateral malleolus. See, midpoint of head of fibula and tibial tuberosity, midpoint to midpoint between the medial and lateral malleolus. Access to the vessels. Femoral artery. Incision is made 10 to 12 cm midpoint of inguinal ligament 1 to 2 cm above it along the projection line. Popliteal artery. Incision is 10 to 12 cm midpoint of popliteal fossa, deviated incision slightly medial to avoid the damage of small saphenous vein. Next is posterior tibial artery. Superior 1/3 of leg, vertical incision of 10 to 12 cm in length from the midpoint of popliteal fossa downward. Middle 1/3 of leg, incision is 10 to 12 cm in length made from medial margin of the tibia along the projection line downwards. Anterior tibial artery, middle 1/3 of the leg, incision is 8 to 10 cm in length along the projection line. Now next is subinguinal spaces. Now it consists two lacuna divided by arcus iliopectinus. Medially and laterally, medially there is lacuna vasorum, lacuna, and laterally musculorum. See, lacuna vasorum, lacuna musculorum. Two lacuna which is divided by arcus iliopectinus. Okay. See, this is arcus iliopectinus which divides lacuna vasorum, lacuna musculorum. Subinguinal space. Inguinal ligament midpoint arcus iliopectinus which divides below the inguinal ligament. It divides the space lacuna vasorum, lacuna musculorum. Now, borders of this lacuna vasorum and lacuna musculorum. Now, superior anteriorly in the lacuna vasorum there is inguinal ligament. Medially there is lacunar ligament. Okay. See, this is lacunar ligament medially. Laterally there is arcus iliopectinus and posteriorly there is pectineal ligament. Anteriorly inguinal ligament, ligament lacunar, iliopectineal ligament, arcus iliopectinus. Fine. These are the borders of lacuna vasorum. In lacuna musculorum, superior anteriorly same inguinal ligament. Fine. Medially there is arcus iliopectinus. Fine. There is no lateral border in this. Posteriorly there is iliac bone. Okay. Now, lacuna vasorum consists of what? Femoral ring. Femoral ring which forms femoral canal for herniation. See, annulus femoralis. And in lacuna musculorum there is iliopsoas muscle and femoral nerve. See, musculus, iliopsoas, and femoral nerve. Now femoral ring, annulus femoralis, opens into femoral canal. Borders are anteriorly inguinal ligament, posteriorly pectineal line, medially lacunar ligament, laterally femoral vein. See, this is annulus femoris, femoral ring. Anteriorly inguinal ligament, posteriorly pectineal ligament, medially lacunar ligament. Means whatever are the anterior, posterior and medial border of lacuna vasorum. It is same, right? Anteriorly inguinal ligament, medially lacunar ligament and posteriorly pectineal ligament. The difference is only lateral one. Here laterally there is a femoral vein. Fine. If a femoral hernia develops, herniated gut will form the femoral ring. Femoral canal. It is a pyramidal shape. Borders are anteriorly superficial layer of fascia lata, posteriorly deep layer of fascia lata, laterally fascia on the femoral vein. Now this femoral canal occurs only when femoral hernia occurs. It is a pathological canal. Loose connective tissue between the femoral vein and lacunar ligament. Here hernia occurs. Most common in females due to broad pelvic. There are two rings, superficial ring and deep ring. In superficial ring, saphenous opening covers by cribrosa, fascia cribrosa or falciform margin of the fascia lata with cornus superior and inferior. Deep ring, annulus femoralis profundus. Anomaly of obturator artery, branch of inferior epigastric artery or internal iliac artery. It is in deep femoral ring. This vessels may pass to the pelvic opening of the obturator canal, but in this case forms arterial anastomosis around the deep femoral ring with obturator artery, also known as corona mortis. Removal of this strangulation causes severe bleeding and may lead to death. Next is adductor canal. It is also called as subarterial canal, Hunter's canal, canalis adductorius. See, it is a musculofacial canal. Fine. It is a musculofacial canal. It has large neurovascular bundles in the anterior region of the thigh. What are the borders? Laterally there is vastus medialis. Medially, adductor magnus muscle. See, vastus medialis. Adductor magnus muscle. Okay, anteriorly there is lamina vasoadductor located between vastus medialis and adductor magnus muscle. Vastus medialis and adductor magnus muscle. Here is magnus, here is medialis. In between this, there is anterior border. Okay. Now sartorius muscle, superficial and adductor longus muscle covers this canal. It begins proximal to the inferior angle of femoral triangle and ends distal to the adductor hiatus. There are three foramen: superficial foramen, inferior foramen, anterior foramen. Superficial foramen, there are femoral artery and vein passes and bounds by superior margin of lamina. Inferior foramen, popliteal artery and vein, hiatus adductorius is there. Anterior foramen, saphenous nerve and artery at vena ginis descendens passes to the lamina vasoadductoria. Topography of the knee. Circular line, 2 fingers width above and below the patella. 2 vertical lines on the epicondyles divided into anterior knee and posterior knee region. Now these anterior and posterior knee region. What are the landmarks? Anteriorly, patella and its ligament, tendon of quadriceps femoris, plica alare, head of fibula. Now Gradis tubercle, insertion of the iliotibial tract and lateral condyle of the femur. Posteriorly, landmarks are Posterior surface during the flexion of the leg on the knee joint, semitendinous and semimembranous muscle is palpated. Medial and superiorly, tendon of bicep femoris muscle also palpated superior and laterally. What are the borders? Anteriorly, superior border is circular line drawn 6 cm above the patella. Posteriorly, same circular line drawn 6 cm below patella. Inferiorly, circular line at the level of tibial tuberosity. Inferiorly, circular line at the level of tibial tuberosity. Medially, line drawn through the posterior margin of medial epicondyle of the femur, and laterally, line drawn through the posterior margin of the lateral epicondyle of the femur. What are the layers? Now layers, anteriorly it is rough, movable, full of folds. Okay. Contains sweat and sebaceous gland. Posteriorly, it is thin and forms fold during flexion. Subcutaneous tissue, here less fat, greater saphenous vein, saphenous nerve is present, infrapatellar branch passes, several bursa are present. Prepatellaris subcutaneous, infrapatellaris subcutaneous, tuberosita tibiae. Superficial lymph nodes are present in the posterior saphenous nerve, lateral sural cutaneous nerve, posterior cutaneous nerve of thigh is present. Superficial fascia is absent in anterior region but present in the posterior, which is popliteal region. Deep fascia, anterior surface, it passes from patella and tendon of quadriceps femoris muscle to reticulum patellae medially and laterally. Bursa under this fascia are prepatellaris subfacialis, prepatellaris subtendinous anteriorly. Infrapatellaris profunda, suprapatellaris is under the tendon of the quadriceps femoris muscle. Now, deep fascia in the posterior is continuation of fascia lata. Serves as aponeurosis covering the muscles. Fascia tensed pulse. Fascia is tensed. Pulse from the popliteal artery is felt. Fascia is removed. Popliteal fossa is revealed. Now, bursa serves as anti-shock, protective function, lubricating function and circulating function. Rete articulare genus. It is located anterior surface of knee joint under the fascia and part of descending genicular artery. And rete patellaris is also located in the fascia of the patellar region. Muscular bundles, first is tibial nerve. Now tibial nerve, see here. Tibial nerve, it descends through the middle of popliteal fossa along the popliteal vessels and enters the canal cruropopliteus. It passes down along with the posterior tibial artery and vein still reaches the medial malleolus. And after passing through the medial malleus, the tibial nerve is divided into lateral and medial plantar nerve. Fine. Now, in the popliteal fossa, tibial nerve gives rise to medial sural cutaneous nerve. See, in popliteal fossa, it gives medial sural cutaneous nerve. Innervates skin and posterior medial surface of the leg. On the leg, tibial nerve supplies three deep muscles, posterior to medially, malleolus to cutaneous branch. Next is popliteal artery. Popliteal artery, it gives off branches around the knee joint, okay, which are superior medial genicular artery, superior lateral genicular artery, middle genicular artery, inferior medial genicular artery and inferior lateral genicular artery. This superior medial genicular artery, it passes under the semimembranous tendon and tendon of adductor magnus muscle to superior condyle of the femur. Superior lateral genicular artery, it passes under the tendon of bicep femoris muscle along the knee joint to superior margin of lateral condyle of the femur. Middle genicular artery is unpaired and it passes at the level of the fissure of knee joint and reaches the cruciate ligament. Inferior medial genicular artery passes to the medial condyle of the femur, passes under the tibial collateral ligament, tendons of gracialis sartoris and semitendinous, and medial head of the gastrocnemius muscle. Inferior lateral genicular artery passes lateral meniscus, then goes under the fibular collateral ligament covered by gastrocnemius muscle. Now there are 4 compartments of the popliteal artery which are distinguished as compartments. First compartment is space between the semimembranous and vastus medius muscle, where tibial nerve, it is 1 to 2 cm lateral to the popliteal artery. The second compartment, space between semimembranous and gastrocnemius muscle, gives rise to the artery of knee joint and muscles. Third compartment lies on the oblique popliteal ligament, gives off branches to the muscles, and fourth compartment is anterior, space between the inferior margin of the popliteus muscle and popliteus tibial muscle, posteriorly by tendinous arc of the soleus muscle. Now, spreading of phlegmons. Fatty space of the popliteal fossa communicates with the superior compartment of the thigh and spaces under the gluteus maximus muscle along the sciatic nerve. Communicates with adductor canal and femoral triangle along the femoral arterial vein. Communicates with the deep spaces of the posterior region of the knee along the popliteal vessels and tibial nerve. Popliteal fossa. It is a shallow depression on the posterior surface of the knee. Borders the superior medially tendons of the semimembranous and semitendinous muscle, superior laterally tendon of the bicep femoris muscle, inferiorly medial and lateral head of the gastrocnemius muscle. Floor is popliteus muscle, plantaris muscle. Fossa has fatty tissue, deep lymph nodes. Neurovascular bundle is superficial to deep, tibial nerve, popliteal vein and popliteal artery. Knee joint is articulation between the medial and lateral condyles of the femur with medial and lateral articular facets of the tibia. Condylar and biaxial joint reinforces by intercapsular ligament and extracapsular ligament. Now, intercapsular ligament are anterior cruciate ligament, posterior cruciate ligament. This anterior cruciate ligament from lateral condyle to anterior intercondylar area, and posterior cruciate ligament from medial condyle to the posterior intercondylar area. Transverse ligament of the knee is between the meniscus. Extrascapular ligament is medially. It is a C shape. It has tibial collateral ligament. Laterally O shape fibular collateral ligament. Anteriorly patellar ligament and tendon of quadriceps femoris muscle. Posteriorly oblique popliteal ligament and arcuate popliteal ligament. Arterial network of the knee joint. In the arterial network of the knee joint, the following 3 groups of arteries are participated. Which are those? Descending genicular artery, okay, which is a branch of femoral artery. Superior medial genicular artery, which is a branch of popliteal artery, okay. Superior lateral genicular artery and inferior lateral genicular artery, which is also a branch of popliteal artery. Inferior medial genicular artery is also a branch of popliteal artery. Now, anterior tibial recurrent artery and posterior tibial recurrent artery, anterior tibial artery and circumflex fibular artery, which is a branch of anterior tibial artery. Topography of the leg. Superiorly, lower border of the region of knee joint. Inferiorly, circular line is drawn through the lateral and medial malleolar inferior. Leg is divided into anterior and posterior region. Topography of the anterior region of the leg. Borders are medial and lateral. Medially, lateral margin of the leg. Lateral, sulcus between the soleus and fibular muscle. Layers are skin, which is thin on the tibia than other regions. Subcutaneous tissue contains branches of the small saphenous vein lateral, sural cutaneous nerve and superficial fibular, which is peroneal nerve laterally. Contains greater saphenous vein and nerve medially. Fascia is similar to aponeurosis, covers extensor muscle of the leg and fibular muscle. Stretches from periosteum of the anterior surface of the tibia and attached to anterior and posterior intermuscular septa to the fibula. Anterior intermuscular septum attaches to the anterior margin of the fibula and divides the muscle of the leg into anterior and lateral compartment. Posterior intermuscular septum, posterior margin of the fibula, divides the muscles of the leg into lateral and posterior compartment. Muscles and neurovascular bundles. Now, there is anterior department. Anterior department, there is tibialis anterior muscle. Anterior department, there is tibialis anterior muscle. Here, tibialis anterior muscle. Extensor hallucis longus muscle. Here, tibialis anterior, extensor hallucis longus muscle, extensor digitorum longus muscle, extensor digitorum longus muscle. Next is fibularis peroneus longus muscle, which is here, and peroneus brevis muscle. Okay. Anterior tibial arterial and veins are also present. Now, lateral compartment, there is fibularis longus and brevis. Fibularis longus and brevis muscle. And superficial fibular nerve is present. Fine. In the posterior compartment, all these remaining muscles are coming. Next is canalis musculo-peroneus superior and inferior. Superior is between the fibularis longus muscle and fibula, from lateral condyle of the femur to the head of fibula. Common fibular nerve passes through this and divides into superficial and deep fibular nerve. Now, inferiorly, border is anteriorly is the tibialis posterior muscle. Tibialis posterior muscle. Okay. Posteriorly is flexor hallucis longus muscle. Sorry, tibialis posterior is here. Flexor hallucis longus is here. Medially, there is fibula. Superiorly, there is peroneus longus muscle. And inferiorly, there is peroneus brevis muscle. Okay. Contents is fibular artery and its vein. Topography of posterior region of the leg. Now, borders are medial and lateral. Medially, vertical line drawn through the medial condyle of the tibia, and laterally is the vertical line drawn through the lateral condyle of the tibia. Layers are skin, which is thin fold easily, and nerve is saphenous nerve. Subcutaneous tissue, small saphenous vein, medial sural cutaneous nerve, lateral sural cutaneous nerve passes through this layer. Fascia is superficial and deep. Superficial covers the triceps surae muscle, where soleus and gastrocnemius muscles are present, and deep is transverse intermuscular septum, covers the deep flexor muscles and extensor muscles located in the deep spaces of the posterior fascial compartment of the knee. This space is bound anteriorly by tibia and fibula and interosseous membrane. Now, muscles are superficial posterior department, deep posterior department. Superficial posterior department are triceps surae muscles, which are soleus muscles and gastrocnemius muscle, and plantaris tendon. And deep posterior department are flexor digitorum longus, tibialis posterior, flexor hallucis longus, popliteus muscle, posterior tibial artery and vein, tibial nerve, fibular peroneal artery and vein. Neurovascular bundles are posterior tibial artery. See, artery tibialis posterior. Okay, this posterior tibial artery, it is a line drawn from the head of the gastrocnemius muscle. Okay, I will explain in this. Okay, see, muscle gastrocnemius, caput medial, head of the gastrocnemius muscle to the medial margin of Achilles tendon. Okay, to the medial head of the gastrocnemius muscle to the medial margin of the Achilles tendon. The initial part of the posterior tibial artery is covered by superior margin of soleus muscle, which passes above the tendinous arc of this soleus tendinous arc of the muscle. It passes through to the malleolar canal and spaces between the tendon of flexor digitorum longus and flexor hallucis longus. It's divided into medial and lateral plantar. Okay, it then later divide into this side, medial and lateral plantar. Okay, the medial plantar vein and nerve passes through the junction. Passes to the junction of fascia of the median and medial part and gives branches. Lateral plantar artery passes between the tendon of flexor digitorum brevis and quadratus plantar muscle. Median plantar nerve innervates muscles of the great toe, flexor digitorum brevis muscle and two medial lumbrical muscles. Now, and gives rise to nerve digitali plantaris propria, which passes to the skin of first, second, third and medial margin of the fourth toe. Lateral plantar nerve innervates muscles of the little toe, adductor hallucis muscles, quadratus plantar muscles, two lateral lumbricus muscle and all interosseous muscles, and gives rise to nerve digitali plantaris propria and passes to the little toe and lateral margin of the fourth toe. Next is anterior tibial artery. Passes to the anterior compartment through the opening of the interosseous membrane and the medial margin of the fibula 4 to 5 cm under the head of fibula. Fibular artery. Initial part is the posterior surface of tibialis posterior muscle along the lateral margin of tibial nerve. Deep peroneal nerve is lateral to the vessels on the knee, then penetrates anterior intermuscular septum and lies lateral to the vessels. Then crosses the anterior to the vessels at the level of the middle point of the malleolus and passes medial to the vessels of the first interdigital space. At the level of intermalleolar line, gives off motor branches to the extensor digitorum brevis muscles, and it passes the motor branch to the lateral tarsal artery. Dorsalis pediis artery. Projected from middle point of the malleolus to the first interdigital space, between the fascial covering of the tendon of extensor digitorum muscles and fascia interossea. Before entering the first intermetatarsal space, it gives rise to arcuate artery, artery metatarsi dorsalis and artery digitalis dorsalis. Next is canalis cruropopliteus. It is bound by tibial artery posterior muscles, which is on anterior side, posteriorly deep layer of fascia of the leg of soleus muscle, laterally there is flexor hallucis longus muscle and medially by flexor digitorum longus muscle. Entrance is anteriorly popliteus muscle, posteriorly tendinous arc of soleus muscle. There is two exist, superior anterior and inferior opening. Anterior tibial artery penetrates the anterior compartment of the leg through the anterior opening in the interosseous membrane. Inferior opening is formed by tibialis posterior muscle and anterior Achilles tendon. Posterior tibialis artery, vein and nerve passes medial malleolar canal through the inferior opening. Ankle joint. Articulation between distal tibia, medial malleolus of the tibia, lateral malleolus of the fibula and talus. Synovial hinge joint is present. Deltoid medial ligament consists anterior tibular, tibionavicular, tibiocalcaneal, posterior tibialar part and collateral lateral ligament. Anterior talofibular ligament, calcaneofibular ligament, posterior talofibular ligament. Due to the shape of the talus, ankle is most stable foot, which does dorsiflex. Ankle often injured when foot is plantar flexed. Lateral surface is sural nerve, medial surface of joint is saphenous nerve, anterior surface is deep fibular nerve. There are three arteries: anterior tibial, posterior tibial and fibular artery. In arthritis, pus may accumulate anterior surface of ankle joint. Topography of foot. Plantar and dorsal foot. A line is drawn middle point of the calcaneus to the head of the fifth metatarsal bone. Borders are medial and lateral. Middle point of the calcaneus to the head of the first metatarsal is the medial. Laterally, middle point of the calcaneus to the head of the fifth metatarsal bone is the lateral. Toe are divided into plantar and dorsal surface by U-shaped line, like arc-like. Topography. Skin in the plantar is thick, especially on the calcaneus and head of the metatarsal, and dorsal is thin and movable. Subcutaneous tissue. Common plantar artery and nerves, cutaneous branch of the medial and lateral plantar artery and nerves are present. And here, dorsally, fat is less, edematous fluid tends to accumulate. Vascular network are rete venosum dorsale pedis, anastomosis with dorsal venous arc, which collects the blood from veins, intermetatarsal space in the greater saphenous vein or drain into saphenous vein along the lateral side. When it drains into greater saphenous vein, it moves to the anterior surface of medial malleolus and venture on venous sections of this vein carried out. In the plantar region, proper fascia is middle part of the sole. It represents plantar aponeurosis, dense and fibers of flexor digitorum brevis muscle begins. In the median part of the sole, superficial and deep, fatty spaces are there. between the tendon of flexor digitorum longus and flexor digitorum brevis muscle. Median part of the sole communicates with subfacial space of the dorsal part of the foot by dorsalis pedis artery, lateral plantar artery. Interdigitalis fatty spaces of the dorsal surface of the toe along the lumbrical muscle. The subcutaneous fatty tissue of the sole along the plantar metatarsal artery and proper plantar digital artery. Medial part of soleus along the tendon of flexor hallucis longus muscle. Lateral part of soleus along the tendon of the flexor digiti minimi muscle and lateral plantar vessels. Deep faces of the posterior part of the knee joint along the tendon of flexor hallucis longus muscle and neurovascular bundles passes through the malleolar canal to the sole medially and laterally. Medially, there is adductor hallucis muscle, flexor hallucis brevis muscle and tendon of flexor hallucis longus muscle. Fibrous septal canal is divided into anterior and posterior. By anteriorly there is flexor digitorum longus tendon and posteriorly quadratus plantar muscle. Now here there is superficial fascia and deep fascia. In superficial fascia it is less developed, contain branches of the saphenous nerve. Sural nerve is innervated by skin of the lateral margin of the foot and little toe. Between these nerves several branches of the superficial fibular nerve is there. Fibular nerve, medial dorsal cutaneous nerve, intermediate dorsal cutaneous nerve, lateral dorsal cutaneous nerve. Deep fascia, it contains fascia cruris, continuation of fascia cruris, extensor hallucis brevis and extensor digitorum brevis muscles under this fascia. Lies on the metatarsal bone and dorsal interosseous muscle. If the fibularis tertius muscle exists, then its tendon is attached to the fifth metatarsal bone. Next is operations, varicose vein on the lower extremity. Now, if there is varicose dilation or varicose disease, valvular incompetency of perforated veins of lower limb is there. Now, blood shift from deep veins to the superficial vein, produce pressure and dilation of the venous wall. Congestion of venous blood is there and inflammation in the venous wall and forms thrombus or thrombo, which is called thrombophlebitis. This dystrophic changes form trophic ulcer. Now treatment is prevent communication between superficial and deep venous system. Indication is varicose disease, trophic ulcer. Contraindication is thrombophlebitis. Aim is elimination of the shunt from the deep venous system. Now first it is done by the method of Troyanov-Trendelenburg's operation. Preventive measures for thromboembolism. Incision is made 4 to 5 cm along the inguinal ligament and parallel to it. Greater saphenous vein is found and double ligature near the place of emptying into the femoral vein. Accessory vein, blood from the lateral and medial surface of the thigh are ligated and cut. This operation is cosmetic but not radical, and a radical operation is necessary. Next method is Linton's operation. Method implies subfacial ligation of the communicant veins along the entire surface of internal surface of leg. Next method is Cockett's operation. Ligate varicose vein through the puncture of the skin ligature is brought in and turned out after passing around the vein through the perforating one. Recanalization of the ligated vein is performed. Removal of the superficial varicose vein by Madelung's operation. Long dissection along the vena saphenna magnus is done. Narrates operation. Multiple dissection for resection of the vein is done. Babcock's operation. Eliminate the vein with the probe. Elimination of the circulation and obliteration of the superficial vein. First is Linser's-Sykars method. Multiple injection of sclerosants is small doses. 3-stage amputation by Pidkov. Indication is done absolute and relative method. Absolute is gangrene, compression and crushing, and burn, which is 4th degree. Relative is vascular disease of the limb, diabetes mellitus, thrombosis of the vessel. Amputation includes the following steps. First step is dissection and retraction of the skin. Second is dissection of the superficial muscle, and third is dissection of the deep muscle. Now next is Grith-Szymanowski osteoplastic amputation of the thigh. The indication is crushing of leg without damage of the knee, vascular disease of the leg. Procedure is Patient is in dorsal decubitus. General anesthesia is given. U-shaped incision is made anterior to the anterior region of the knee. It starts 2 cm proximal to the lateral epicondyle of the femur and pass down below and over the tuberosity. Continuation of medial and terminates 2 cm above the medial epicondyle. Soft tissue is divided along the line. The proper patellar ligament is cut proximal to the tuberosity. Posterior flap is cut at the level of transverse fold in the popliteal fossa with slight convex down. Flap is divided and pull up. The soft tissue are intersected at the level of articular cleft. Synovial membrane at the knee joint in the anterior flap is removed. Soft tissue of the anterior and posterior flap is retracted above at the level of epicondyle and femur is dissected. Bone saw line of the femur and patella attached to each other and catgut sutures are made. Proper patellar ligament is connected with the tendon of the flexor muscle and interrupted silk suture are applied to the skin. Now there are disadvantages and advantages of this. What are advantages? Stump allows considerable weight bearing, thus permits considerable independency without prosthesis, which is Pirgov's amputation. Grith-Shimovsky operation useful for some patient with ischemic limb who appears to have good perfusion below the knee but does not have posterior flap of the skin, thus allowed to undergo below knee amputation. Disadvantages is operation is complicated. Necrosis of the tuber of the calcaneus occurs in some cases due to damage of calcaneus vessels. Next is Pirgov's osteoplastic amputation of the leg. Amputation of the leg is distal 1/3 part, for example, through the ankle joint. Indication is gangrene, severe injury to the bone and soft tissue, and tuberculosis. Procedure. First incision. Inferior margin of the medial malleolus to lateral malleolus. Dorsal surface of the foot. Second incision. Inferior margin of the medial malleolus downward to the sole and then upward to the lateral malleolus. It is cut deeply until it reaches the calcaneus. Lateral ligament is dissected through the opening of the first incision. Foot is flexed. Posterior part of the capsule of the ankle is cut. Ankle joint is cut. Calcaneus is sawn by an arc saw till second incision level. Damaged part of the foot is removed. Anterior tibial artery and vein is ligated on the anterior flap. Posterior tibial artery and vein is ligated on the inferior part. Deep fibular nerve is dissected. Distal end of the foot is sawn horizontally. Lateral shape edge of fibula is smoothened by gauge. Calcaneus is sawn and triple catgut suture is applied to the stump of tibia. Tendon, ligament and fascia stitched with catgut suture. Skin with the silk suture and plaster of Paris is applied. Next is amputation of leg by length. Amputation of upper 1/3 of length. Level of 5 to 7 inches below the knee joint. Indication is gangrene, severe injury to the bone of the soft tissue and tuberculosis. Incision of the skin with large anterior flap than the posterior flap. Fibula is cut 2.5 cm shorter than the tibia. Crest of the tibia is beveled. Muscles of the posterior anterior lateral side are larger, while cutting through this muscle they cannot be divided except musculus gastrocnemius and musculus plantaris. Amputation of middle 1/3 of the leg. Same as upper 1/3, but fibula is not removed. Musculus tibialis anterior is cut and cover tibia. Other muscle groups are retracted higher and bone saw line. Muscular bellies are slided gradually downward and forward to the line. Sharp's amputation of the foot. It is transmetatarsal amputation. It is done because ischemic gangrene associated with diabetes mellitus, arteriosclerosis with well demarcated line or infection. Procedure is incision of the skin with large plantar flap, then dorsal flap is made. Periosteum is cut 1 to 2 mm. Metatarsal bone is sawn. Bones end are polished to prevent the damage of the soft tissue and flap is sutured. If only one toe is involved, usually first or fifth, we can consider using Grangeau's method. Disarticulation of foot by Lisfranc, Chopart and Garanzo method. Indication is injury, gangrene due to peripheral vascular insufficiency, atherosclerosis, obliterating endartitis, diabetes mellitus, severe infection. Lisfranc's disarticulation. Level of the joint tarsometatarsal joint, Lisfranc joint. Key of the joint, ligamentum cuneo-metatarsus mediae, may cut through second metatarsal bone. Chopard's disarticulation. Level of the joint is transverse tarsal joint, Chopard's joint. Key of the joint is ligamentum bifurcation. In both methods, skin incision can be made with a large plantar flap than the dorsal flap. Garanzo's disarticulation, removal of first or all toes, one or all toes. Indication is crushing of all the toes or necrosis due to frostbite leading to dislocation of the metatarsophalangeal joint. Occurs in rheumatoid arthritis, and amputation of toe may sometimes be preferred to forefoot arthroplasty. What is the procedure? Patient is dorsal, decubitus, general anesthesia is given. Dorsal and plantar incision runs across the toe, sweeping into the web space and passes across the foot. Longitudinal incisions are continued along the lateral and medial border of the foot to the level of head of first and fifth metatarsal bone. Skin's flap are retracted. Complete uncovering of the metatarsophalangeal joint is done. All toes are flexed to the sole. Line of the metatarsophalangeal joint is dissected by one dorsal incision. All toes are divided together by curved scissor. Metatarsal head cartilage is not removed. Digital arteries are ligated in the space between the metatarsal bone. Dorsal and plantar flap are connected with each other by interrupted silk suture. Next is puncture and arthrotomy of the hip joint. Puncture of the hip joint. There are two approaches. Lateral approach. Most common is used at the point when patient is in supine position. Needle is inserted strictly to the anterior posterior direction from the point of midline on the tip of the greater trochanter of the femur to the point between the medial and median 1/3 of the inguinal ligament. Needle is pulled out from the point of the pulsation of the femoral artery to the medial margin of the sartorius muscle. Anterior approaches, needle is inserted above the greater trochanter and directly transfers till the head of the femur. Needle directed upward and reaches the capsule of the hip joint. In inflammation with pus, drainage of pus by arthrotomy is insufficient. Resection of head of the femur is more often manipulated. Langenbeck's resection of the hip joint. Patient is in supine position with operative leg flexed. Dissection of the skin and soft tissue layer by layer is done between the posterior superior iliac spine of the and tip of the greater trochanter of the femur. To the posterior margin 5 to 6 cm distal to the tip of the greater trochanter of the femur. Fascia is dissected with a blunt instrument. Fibers are separated from the gluteus maximus muscle to reach the space between the gluteus medius and piriformis muscle and penetrate to the capsule of the hip joint. T-shaped dissection is made. Joint capsule is opened to expose the neck of the femur. This makes the dissection of the leg of the ligament of head of femur easy. Extremity is rotated laterally. Head of the femur is dislocated and sawn with Giggles saw. Damaged part of acetibulum and sharp edge are removed. After resection, neck of the femur is fixed to the acetibulum and sewn together at the edge of the removed capsule. Wound is sewn layer by layer and extremity is fixed by plaster of Paris. Next is puncture, arthrotomy and resection of the knee joint. Puncture of the knee joint, carried out 1 to 2 cm from the apex or base of the patella. Puncture is done superiorly. Needle is inserted downward and into the joint, between the posterior surface of the patella and epiphysis of the femur. Wojno-Jasinski arthrotomy of the knee joint. Knee joint opened by 4 incision. Anterior incision. 2 anterior lateral incision made. Skin, subcutaneous tissue, fascia and retinaculum of the patella. It is dissected by grooved probe. Capsule of the knee is stretched and opened along the length of dissected skin. Posterior incision is dressing forceps is inserted. Anteromedial opening to the space between the medial condyle of the femur and medial part of the capsule of the knee joint. Then forceps is pushed until the protrusion of the skin is seen. Posterior medial incision is made. Posterior lateral is avoided due to fibular nerve damage. Textor's resection of the knee joint. Patient is in supine position with the leg bent Arc-shaped dissection is done. Skin, subcutaneous tissue and superficial fascia is dissected. Anterior surface of the knee joint is made to connect and posterior edge of the medial and lateral epicondyle of the femur. Dissection passes 1 cm below the tibial tuberosity. Above the tibial tuberosity, ligament of the patella is dissected. Joint capsule is opened and soft tissue with the patella is folded up. All the compartments of the knee are exposed. All damaged cartilage, bone and sharp edges are removed by saw. Flap is sutured layer by layer. Puncture, arthrotomy and resection of the ankle joint. Puncture of the ankle joint is anterior on the medial or lateral malleolus. Puncture on the lateral malleolus, needle inserted between the 2 cm superior on the lateral malleolus and extensor digitorum longus muscle. Puncture on the medial malleolus, needle is inserted between 1 cm superior to medial malleolus and extensor hallucis longus muscle. Both needle penetrates to trochlea on respective side. Woins-Yasinski arthrotomy of ankle joint. Joint is cut in 3 dissection. Patient is in supine position. Anterior medial dissection 3 to 4 cm longitudinally along the lateral edge of medial malleolus. Retinaculum of extensorum superioris muscle is cut by a grooved probe inward from the osteofibrous canal of the tibialis anterior muscle. Then the capsule is stretched and opened. Anterior lateral dissection 3 to 4 cm longitudinally laterally from the tendon of the extensor digitorum longus muscle by grooved probe. Retinaculum is cut between the talus and lateral malleolus. Capsule is opened with scalpel. Draining tube is inserted for further drainaging of the joint with antibiotic solution. Posterior medial dissection. Dissection of skin, subcutaneous tissue and superficial fascia is done posterior from the medial malleolus 6 to 8 cm. Retinaculum of flexor muscle is opened by grooved probe. Neurovascular bundles, posterior tubular vessels and nerves, stretched anteriorly with blunt hook anterior. Then placed on capsule of ankle joint between the extensor digitorum longus, extensor hallucis longus tendon. Then dissection is introduced. Drainage tube is transversely to the lateral malleolus. Affected limb is immobilized with foot flexed. Next is Kocher's resection of the ankle joint. Dissection of the skin, subcutaneous tissue and superficial fascia 9 to 10 cm above the lateral malleolus and 1 cm posterior from the fibula, posterior from the lateral malleolus. Lateral malleolus is flexed and dissected until the tuberosity of 5th metatarsal bone. Retinacula of musculi perineurium superius et inferius is dissected. Fibrous sheath of fibularis peroneus longus and fibularis peroneus brevis muscle and tendons are opened by grooved probe and stretched anteriorly. Capsule of joint is separated and fixed underneath the periosteum. Soft tissue is pulled anteriorly and same procedure posterior from the tibia. Foot is rotated laterally and stretched. Ligament is dissected from the lateral malleolus to the direction of calcaneus and talus. Foot is extended more laterally and talus is dislocated. Total removal of talus is astrectomy. Bone suture is done layer by layer and affected limb is immobilized. Okay. Now till here we covered the topography of lower limb and its operations. Keep learning, keep watching. Thank you.